So now we're going to talk about the effects of strokes. That is, how will patients present after a specific stroke. Remember, we can have strokes or occlusion of blood vessels in any part of the vasculature, including the middle cerebral vascular, the vessels, the anterior cerebral vessels, posterior cerebral vessels, anything that I mentioned a lot of vessels. You can get blockage there, and then you can get an ischemic stroke. And the way you're going to get tested on this is they're going to tell you about a patient that is having problems, specific focal neurological problems. You're going to have to be able to identify what part of the brain got stroked out, got blocked up, and that would cause all these neurological deficits. Now, there's going to be a wide bunch of presentations. There's a whole page of this on first aid that I can never memorize. But the good news is that you don't need to memorize any of this if you understand the anatomy. So, honestly, we've been this whole chapter we've been working towards is to understand this. So, if you can understand what I'm going to be talking about next, then I think you have a firm grasp of everything you need to know. So, this will be tough. But if you can get it, then it basically reinforces everything that you've already learned. We're going to cover the spinal cord tracts, cortical spinal tracts, spinal thalamic, medial lemniscus. We're going to cover vascular perfusions. We're going to cover functions of the cerebral cortex, blah, blah, functions of all parts of the brains. So I'm pretty excited about this. And the first thing we're going to talk about is what happens if we get a stroke in the middle cerebral artery. So either maybe an embolus comes up from the rest of the body and lodges in your middle cerebral and blocks it all up. Or you can get a thrombotic stroke because you're a vasculopath. You have same risk factors for heart attacks. It causes thrombosis in your middle cerebral artery. And then the things I want you to think about is what area is affected. So I want you to remember the homunculus, and as well as the perfusion of the middle cerebral artery to the cerebral cortex. So do you remember what the homunculus, what part of the body is affected in the middle cerebral artery? I guess it's perfusion area. Remember, middle cerebral artery is lateral, and the homunculus, the lateral part, this is lateral, remember this half of the brain, is arms, upper body, and face. So you're going to get the decreases in lateral motor and sensory cortex. So the upper limb and face have decreased sensation and movement. And then the other important thing was that the Wernicke's area and the Broca's area are all in the lateral parts of the brain, as well as the parietal lobe. So if you know these areas, we already know what symptoms these patients are going to present with, okay? This one is going to present with, obviously, contralateral. It's going to be contralateral paralysis and sensory loss of the face and upper limb. Because if you have to know that this is contralateral, and you're going to know that because you already know our spinal cord tracts, and you know that they cross. You know they cross at different levels, but they both cross, okay? And then Wernicke's and Broca's, what is going to happen here? Remember, if it has to depend on which side of the brain we're talking about. Remember, there's a dominant speech side of the brain, and it's usually left. So if you have damage on the dominant side of the brain, you're going to get aphasia. If you have a non-dominant damage, you're going to get hemi-neglect. Remember that this is due to the parietal lobe leading to hemi-neglect. Remember, the parietal lobe is responsible for perception, and if it's damaged in the contralateral, the non-dominant side of the hemisphere, you're going to get hemi-neglect. That is, let's say that it's the right parietal lobe got damaged, is non-dominant. It's contralateral hemi-neglect, so the left side of the world is totally gone. It does not exist for this patient. There is nothing on the left. It does not even exist, okay? So, in summary, we can figure all these symptoms out. Do not memorize these symptoms. You already know this if you can remember the homunculus and remember the middle cerebral artery perfusion to the cerebral cortex. We can do the exact same thing for the anterior cerebral artery. This one's even simpler. Just remember the homunculus. What part of the motor and sensory cortex does the anterior cerebral artery perfuse? Remember, it perfuses the medial part, and the medial is the lower limb. Remember right here, these are the legs. So then obviously your symptoms are, which side is going to be contralateral or ipsilateral? Remember, again, it's going to be contralateral. Spinal cords cross at the spinal cord tracts will cross, and so it does the contralateral side. So you're going to have lower limb paralysis and sensory loss. Didn't add that. So very simple. You don't have to memorize that as long as you know the homunculus, and the anterior cerebral artery, and just know that you know your spinal cord tracts and where they cross. Okay, next is the lenticulostriate artery strokes. We've talked about this before, so I don't really need to cover this that well, but remember what areas are affected. Remember that it can either be the internal capsule or the thalamus. Okay, remember this is the deeper structure of the brain, or lenticulostriate arteries. Remember this is it branches off of the middle cerebral arteries and they go to the deep structure of the brain. And then the symptoms, then if it hits the internal capsule, what symptoms are you going to get? Remember, internal capsule is purely motor. Okay, this is where the motor cortex branches go through the internal capsule to the rest of the body. And then the thalamus, what is this? If you damage this, what are you going to get? You're going to get sensory symptoms. Okay, this is the sensory relay center. So it's going to be pure motor or purely sensory deficits. And just to remember that again, it's contralateral. These are both contralateral because remember, all of these things will cross at some point in the body. Whether it be for the spinal thalamic tract, it's going to cross at the lower part of the spinal cord, or the motor deficits will cross at the medullary pyramids. Remember that. Note that there are absence of cortical signs. That's signs of damage to the cerebral cortex, like aphasia, perceptions, problem like hemi-neglect. Because there is no damage to the cerebral cortex, the lenticulostriate arteries go to the deep structures of the brain. Let's just ignore this here. I don't want to redo this lecture, so we'll ignore this. This was a reminder for myself. Mistakes, my bad. Alright. Now, there's a couple other vessels that we haven't talked about yet. We covered the big one, the big two. Before we go into the other ones, I need to talk to you about the rule of 4's. So, the rule of 4's, we've already talked about two of the rule of 4's here. We talked about these two. That there are 4 cranial nerves originating above the pons, 4 in the pons, that's cranial nerves 5 to 8, all originate in the pons, and the cranial nerves 9 to 12 originate in the medulla. Then we also have 4 midline cranial nerves. Remember, these are all divided into 12 except for 1 and 2, so the cranial nerves 3. Let's see, 3, 4, 6, and 12 all are midline cranial nerves. The next rule of 4's that you need to know are that there are 4 midline structures that begin with M. Okay, please memorize this. It's going to make your life a lot easier. Just do it. Put it in a little bit of work. Memorize these 4 medial structures. First one is the motor pathway. That is also known as it's basically the cortical spinal tract. Okay, that's midline. Same for the medial lemniscus. Medial longitudinal fasciculus, which I will talk about later. Damage to this causes the internuclear ophthalmoplegia, if you already learned that. And finally, the medial cranial nerve. So that's also all very easy. The M just stands for medial, so they're all medial structures. And then you have the motor pathway, which is also medial. Next, there are 4 structures to the side that begin with S. So the side means lateral structures. Okay, we talked about the medial structures. Now we're talking about the lateral structures. They all start with S. There's the spinal cerebellar pathway that can cause ataxia of the arm and leg of the same side if it's damaged. And then the spinal thalamic pathway, sensory portion of cranial nerve 5, and the sympathetic pathways. All of these structures are in the lateral portions of the basically the brainstem. Okay, please memorize these rule of 4's. It's going to make your life a lot easier. Because this is all anatomy, and the strokes that we're going to talk about are all based on the anatomy. And so what we're going to do to apply this is we're going to identify what level of lesion is. What is the pons affected? Is the medulla affected? And that will tell us which cranial nerves will be involved. So remember, if your pons gets hit, which cranial nerves were in the pons? Remember, it's the rule of 4's. It's cranial nerves 5 to 8. If it's the medulla, you know it's going to be cranial nerves 9 to 12 might be affected. Then we have to identify if the lesion is going to be lateral or medial. Remember, we talked about the medial and lateral structures. So if we know it's a medial involvement of the medulla, for the cranial nerves, for just the cranial nerves, remember which cranial nerves were medial. Remember, it's factors of 12, so it's 3, 4, 6, and 12. And remember, we know that the medulla is only 9 to 12, so we're only talking about cranial nerve 12, and we're talking about medial. So we do know that the cranial nerve 12 happens to be medial, so that's going to be affected. And then we think about other medial structures. Remember that these are all medial structures, so these can all be affected by a medial lesion to the medulla, the motor pathway, the medial lemniscus, medial longitudinal fasciculus, and then cranial nerve 12, okay? And then we have to deduce by understanding the function of all these cranial nerves and the tracts involved, whether you have sensory or motor deficits or both. And then the other key part is, will the deficit be ipsilateral or contralateral to the lesion? Okay, so this sounds like a lot, but just understand it's very simple. It's a simple concept of understanding the anatomy and then understanding what deficits will arise when we get damage to a specific part of the body. Okay, so without further ado, let's go into the anterior spinal artery. I've drawn it here. Anterior spinal artery. Right here, it goes to the very middle. This is the anterior spinal artery right here. Let me just redraw that. Okay, this is the anterior spinal artery. It perfuses the medulla, and you can tell it's a medial medular perfusion. And this is called medial medullary syndrome. This tells you everything you need to know about stroke to the anterior spinal artery. Remember, we talked about medulla, we talked about medial. What cranial nerve was medial in the medulla? Remember, it's only cranial nerve 12. The other ones are going to be lateral. What other things are affected? What other medial structure? What are the 4 M's that are medial structures? Well, remember, it's the motor tract, which is the corticospinal tract, and then there's the medial lemniscus. Okay. So then from these 3, we can already know our symptoms if we get damage to them. Okay. What will happen to damage to cranial nerve 12? Remember that mnemonic that we talked about? What was it? It was called lick your wounds. Your tongue is going to deviate ipsilaterally. What's going to happen to if you get damage to the lateral corticospinal tract? Well, you're going to get contralateral paralysis of your upper and lower limbs. Simple as that. And the medial lemniscus. What was that responsible for? Remember, it was responsible for proprioception, vibration, sensation, light touch. So you're going to get deficits. You're going to figure out all these deficits by knowing your anatomy and knowing that this is a medial medullary syndrome. That's going to tell you everything you need to know. Okay? So the next one is going to be anterior inferior cerebellar artery. That is this one right here popping out. So this is going to the pons, and you can see it's more lateral. Okay, so this is a lateral pontine syndrome. So this is the pons I'm going to outline here. Okay, so this is a lateral pontine syndrome. And so we can think about cranial nerves. So pons is cranial nerves 5 to 8. And if you think about which ones are lateral and which ones are medial, remember that which one was the medial structure. Remember, cranial nerves that were factors of 12 was medial. So we're going to ignore 5. So that tells us that cranial nerve 6 is going to be medial. So we're going to forget about that because we're in lateral right now. So cranial nerves 5, 7, and 8 are affected. What other lateral structures? Remember the rule 4 for the side structures or the lateral structures all start with S. So that's going to be cranial nerve 5, 7, 8, spinal cerebellar, spinal thalamic, and your sympathetics. Okay? We know all these areas that are affected, so now we can deduce all the deficits that are going to occur. Okay? Cranial nerve 5, what was that responsible for? Remember, it was pain and temperature sensation in the ipsilateral face. Okay, so that's going to go decrease. Cranial nerve 7, what does that do? You have to know all the functions. The cranial nerve 7, where it's facial motor response, and remember that it also has parasympathetic functions, including lacrimation, salivation, and taste. It does taste for the anterior 2/3 of the tongue. Cranial nerve 8, what does that do? Remember, it's the inner ear stuff. So if you get damage to it, you're going to get vertigo, you're going to get vomiting. And then next is the spinal cerebellar. I mentioned that briefly. So this is going to present with ataxia and dysmetria of the ipsilateral arms and legs. Spinal thalamic, we should know. What is going to be lost? Well, you're going to lose pain and temperature. And what side of the body is it going to be to the lesion? Remember, it's going to be contralateral because the spinal thalamic tracts cross. And if you lose sympathetics to the body, what you're going to get? Well, sympathetics to the face, really. Remember, the sympathetics damage is called the Horner syndrome. Remember, horny Pam. Okay, so you're going to get ptosis, meiosis, and hydrosis. So this is a bunch of hunk of symptoms. You can already understand all of them by knowing the lateral pontine syndrome and your rule of 4's. Okay, so this makes it a lot easier to understand everything. Next is going to be the posterior inferior cerebellar artery, and that's over here coming out. Okay, so you can tell that's going to be the medulla, and that's going to be lateral. Okay, so the lateral medulla. So we can again work on the cranial nerves that we're going to be talking about. Cranial nerves, medulla is 9 to 12. So 9, 10, 11, 12. And we're talking about lateral, so we'll exclude our medial structures, which is 12. So it's 9, 10, 11. And the other lateral structures were the same as before. Remember, these are all to the side, so they all start with S. So we have the spinal cerebellar, we have the spinal thalamic, we have the sensory portion of the cranial nerve 5, and then we have the sympathetics. So this is pretty simple. We already talked about everything. The key difference here is that cranial nerves 9, 10, and 11 are involved, and these are involved in dysphagia, and basically dysphagia, hoarseness. You get decreased gag reflex. This is a differentiating feature. So if you have a patient with stroke symptoms and you see this, honestly, you pretty much already know that it's lateral medullary syndrome. Nothing else is going to cause this, so you're going to have involvement of the posterior inferior cerebellar artery. We've went through all these other symptoms already in our last with the anterior inferior cerebellar artery, so I don't think we need to belabor it. So next, we finished with our rule of 4's, and we're going to go to the basilar artery right here. Now this artery perfuses the brain stem. It's a big fat artery. It goes to the midbrain, the pons, and the medulla. Okay. It's also going to perfuse your cortical and spinal and cortical bulbar tracts. I'm just going to talk about the symptoms here. It's pretty easy to understand, but I'll just introduce it. This is the idea of a locked-in syndrome. You're going to get total body paralysis, and that is because all your cortical spinal tracts and bulbar tracts, they all run through your pons, they run through your brainstem to the spinal cord. So you're going to knock out all those. You're going to get total body paralysis, but you have sparing of the reticular activating system. So there is preserved consciousness. Okay, total body paralysis. So they know what's going on. They just can't move their body, so they're locked in. The couple of other things that are preserved. So they preserve consciousness. They understand what you're talking. If you talk to them, they understand what you're talking about. They can still move their eyes vertically. They can still blink, and they still have skin sensation. However, they can't move their body at all. So this is a pretty sad syndrome. It's a pretty miserable way to live because you are still awake and conscious, but you can't do anything. Okay. Finally, we have the posterior cerebral artery. This one's a lot easier to understand. Or posterior cerebral artery. What is the main cerebral cortex that is involved? The answer is the occipital lobe. And what was the function of the occipital lobe? Remember, that was the visual cortex. When you get damage to that, what you're going to get is something called contralateral hemianopia with macular sparing. So let's say it's damaged to the right posterior cerebral artery. And you're going to get a left-sided, remember this to the left, contralateral, so left-sided, hemianopia, so hemi is half of the eye, doesn't work, and then macular sparing is going to lead to this. So this part is fine, okay? So that's why you get contralateral hemianopia with macular sparing. And we've talked about visual fields already, so refer to that section if you don't understand what's going on. So in summary, this is a big slide with the summary of all our stroke symptoms. You can stop here, you don't have to listen to this, but this is a good review of what areas affected and what symptoms you will experience from this, from strokes to different parts of the body. And this is basically, if you know this slide right here that consolidated all the information, you're good to go. Okay. So the middle cerebral artery, what area is affected? Remember, the middle cerebral artery is lateral parts of the cerebral cortex. So it's lateral, motor, and sensory cortex. And remember, the big speech centers that are lateral are the Wernicke's and the Broca's area. And so the symptoms you would experience would be contralateral paralysis, where it's contralateral. And then you can get paralysis and sensory loss of the face and the upper limb. Remember, if it's the dominant side of the brain, your dominant speech side of the brain, which is usually on the left, you're going to get aphasia because of knockout to your Wernicke's and Broca's area. And if it's non-dominant, you're going to get hemi-neglect. Alright, moving on to the anterior cerebral artery. Remember, what part of the brain does that do? What part of the motor and sensory cortices? Remember, that's the medial side. And what part of the body does that do? That does the lower limbs, okay? So you're going to get, is it going to be ipsilateral to lesion or contralateral? Remember, it's always it's contralateral. It's super easy because these spinal cord tracts cross. So you get contralateral paralysis and sensory loss of your lower limbs. Next is the lenticulostriate artery. How does this present? Do you remember? Remember, it hits, what parts of the body does it hit? It hits the internal capsule and the thalamus. So it's going to present with either pure contralateral motor weakness or pure sensory contralateral deficits of your face and body. Okay. Next is the anterior spinal artery, or the medial medullary syndrome. And this is when you start using the rule of 4's, okay? Medial, medullary. So cranial nerve, do you remember which cranial nerve is medial and in the medulla? Or only cranial nerve 12 is medial and in the medulla. And then what other structures are medial in the brainstem? Remember, it's the 4 M's, okay? There's the medial lemniscus, there's the motor pathway. We talked about the medial cranial nerves. There's also the MLF, which we're not going to talk about. So how's this going to present? Cranial nerve 12, remember that. Cranial nerve 12, lick your wound, so tongue deviates ipsilaterally. Lateral cortical spinal tract damage, is it going to be contralateral or ipsilateral? Remember, it's going to be a contralateral paralysis of your upper and lower limbs. And then the medial lemniscus is responsible for proprioception and vibration sense. Remember, that is also contralateral. Okay. Next is the anterior inferior cerebellar artery. This is the lateral pontine syndrome. So cranial nerves in the lateral pons, remember, are 5, 7, and 8. Remember, cranial nerve 6 is medial, so we're going to forget about that one. And then the other lateral structures that run through the pons are the spinal cerebellar, spinal thalamic, sympathetics. And then we can just deduce all of the deficits we're going to get. And then I want to point out this one. Paralysis of the face and forehead sparing is pretty characteristic of the anterior inferior cerebellar artery. Remember the forehead sparing, we talked about that. There's the dual innervation of the forehead from both sides of the brain. So if you knock out one side, the forehead is still gets innervation from the other side of that remaining side of the brain. So your forehead can still move, but the lower face is only on one side. It only gets innervation from the contralateral brain. So your forehead, your face is paralyzed, but your forehead is spared. We've talked a little bit about all these functions, so I'm not going to belabor it. Same thing for the posterior inferior cerebellar artery, or the lateral medullary syndrome. Remember what cranial nerves are in the lateral medulla? When it's everything but cranial nerve 12. And then we've already talked about lateral structures in the brainstem. So cranial nerve 9, 10, 11, and then all of these. And then remember, this is their big differentiating feature here. Dysphagia, hoarseness, decreased gag reflex. Alright, basilar artery. What was the presentation of this? How did this present? Remember, this is the locked-in syndrome. This is the miserable life where you can't move your body, even though other than you can communicate basically by moving your eyes and blinking, basically, and you're still aware of what's going on, unfortunately. Finally, posterior cerebral artery. What part of the area is affected again? Remember, it's the occipital lobe. And how does this present? What was that key, super complicated word for how does this present? Remember, it's a contralateral hemianopia with macular sparing. Alright, so I have talked a ton. Honestly, this chart you should know, but don't memorize it. Just memorize, know the anatomy. Know that the PICA, posterior inferior cerebellar artery, affects the lateral medulla. Know your rule of 4's, know your homunculus. That's all you need to know. This is stuff that we've talked about throughout the neuroscience, the neurology section. And then everything else here to the right, you can deduce. You should already know based on your firm grasp of the anatomy. Alright, thank you.